Welcome to Roadmap to Residency Evidence-Based Applications. Hello everyone, I'm Abhiraz, and in this video we will be discussing about respiratory pharmacology, focusing mainly on asthma and COPD treatment. So COPD and asthma drugs, they generally consist of short-acting bronchodilators, long-acting bronchodilators, and steroids. The short-acting bronchodilators consist of Albuterol and Ipratropium bromide. The long-acting bronchodilators consist of Salmeterol, Formoterol, Tiotropium bromide, and then there is steroids. So the beta 2 agonists, they activate the adenylate cyclase and then they increase the CAMP, cyclic adenosine monophosphate. And this increase in the CAMP relax the bronchial smooth muscle. The short-acting beta 2 agonists like albuterol are generally used as a nebulizer or inhaler and is used during acute attacks. The long-acting salmeterol and formoterol are not used as monotherapy for asthma and are always used only with inhaled corticosteroids. The systemic side effects are rare. However, it can cause tremor and arrhythmias. The muscarinic antagonist, so they stimulate the vagus nerve, and then the acetylcholine is released, and then it causes bronchoconstriction. Okay, now this is the basic mechanism. So whenever the vagal nerve is stimulated, and then acetylcholine is released, and then there is the bronchoconstriction. What muscarinic antagonist does is that it blocks the M receptors on the smooth muscle, and then it prevents the bronchoconstriction. The short-acting are ipratropium, and long-acting are tiotropium. Steroids. Some of the inhaled steroids are beclomethasone, fluticasone, budesonide. Oral are prednisolone. Some IV like methylprednisolone. They inhibit the synthesis of cytokines and they bind to glucocorticoid receptor. They have many immunosuppressive effects. The inactivation of NFK beta, that is a transcription factor, it induces the production of TNF alpha, which is common. The common side effect of a steroid is oral candidiasis, that is oral thrust. So that's why the patient is instructed to rinse their mouth after inhalation of the oral or inhalational steroids. Okay. Now after the inhalation of the inhaled steroids like fluticasone, then the patient is told to rinse their mouth. Whereas if not, then they can develop oral candidiasis. And this is a very common question that is asked in the examination. So there are some special asthma drugs like leukotriene receptor antagonists like montelukast, okay, which are generally useful in aspirin-sensitive asthma. And there is Xeliotone, okay, which is 5-lipoxygenase inhibitors, which blocks the conversion of arachidonic acid to leukotrienes. Both of these drugs are taken per orally. So ecocyanins, so there is lipids, okay, which contains the cell membrane, and this acts up, and this gets acted upon by phospholipase A2, which forms the arachidonic acid. Now, this arachidonic acid by the uh, enzyme lipoxygenase get converted into leukotrienes, or by cyclooxygenase can go to form thromboxane and prostaglandins. Now, these are inflammatory mediators. Okay, now these are blocked by Xeliotone, and the leukotrienes are inactivated by multileucast or leukotriene default. So theophylline are methylxanthines. They have a multiple complex mechanism. They cause the bronchodilation, likely through the inhibition of phosphodiesterase, and they cause less hydrolysis of the CAMP. So they increase the CAMP. So as we have talked earlier, okay, it has a multiple complex mechanism. So theophylline, it can also downregulate the inflammatory cell functions, and they generally have a narrow therapeutic index. The levels must be monitored, dose must be titrated. So goal is a peak serum concentration of 10 to 20 mg per liter, and we have to maintain at that level. So asthma, okay. So first there is exposure to antigen. So the first one that we can prevent for the asthma to develop is the avoidance of triggers, okay. So that antigen then activates the mast cell, okay, or we can see IgE production can then activate the mast cell. So omalizumab can just inhibit the IgE production, and then we can use steroids, Xeliotone, cromolyn to just inhibit the production of leukotrienes, histamine. Okay, and if the leukotrienes, histamine are already produced and we want to prevent the bronchoconstriction, then we can go with beta agonist, muscarinic antagonist, and theophylline. So this is a basic treatment management of asthma. Whereas if you talk about the acute exacerbation of COPD, then we go with treatment like oxygen, nebulized albuterol, or we can add ipratropium. We can have IV or oral corticosteroids. We can add prednisolone 60 mg daily, methylprednisolone, antibiotics, fluoroquinolones, and amoxicillin clavulanate. So this is the basic outline of COPD chronic therapy. So first we go with short-acting bronchodilator, and then we add the long-acting bronchodilator, and then we add the inhaled corticosteroids, and then we go for oxygen or surgery. Okay, and in case of refractory diseases, we go with theophylline or roflumilast. So this is the basic outline of asthma chronic therapy. In the step one, we only indicate the short-acting bronchial drugs, okay, bronchodilator, only when there are symptoms. Okay, in step two, we add a low dose inhaled corticosteroids. In step three, we go for medium inhaled corticosteroids or low dose ICS plus a long-acting bronchodilator. In step four, we go for medium ICS plus a long-acting bronchodilator. In step 5, we go for a high ICS plus a long-acting bronchodilator. And in step 6, we go for high ICS, LABA plus a oral steroids, okay? Whereas we can add theophylline or omalizumab as necessary from step 2 to step 6. So 30-year-old woman presents to her primary care physician with complaints of recurrent episodes of wheezing, chest tightness, coughing, and shortness of breath, especially at night and during exercise. She reports a history of similar symptoms in childhood and states that they have been worsening over the past few weeks despite her rescue inhaler use. Physical examination reveals expiratory wheezes bilaterally. Spirometry demonstrates reversible airflow obstruction with an increase in forced expiratory volume in 1 second of more than 12% and 200 ml after administration of a short-acting beta agonist. Which of the following is the most appropriate next step in management? Prescribe an inhaled corticosteroid as monotherapy. Prescribe a leukotriene receptor antagonist as monotherapy. Prescribe a long-acting beta agonist as monotherapy. Prescribe an inhaled corticosteroids and a long-acting beta agonist as combination therapy, or prescribe an oral corticosteroid for short-term use. So prescribe an inhaled corticosteroids and a LABA combination therapy. So combination therapy with an inhaled ICS and a long-acting LABA is recommended as the preferred initial treatment for asthma control in patients with persistent symptoms, as evidenced by the patient worsening symptoms despite rescue inhaler use. Monotherapy with either an ICS or a LABA alone may not adequately control the patient's symptoms, especially in moderate to severe asthma. So 65-year-old man with a history of long smoking presents to his primary care physician with complaints of worsening dyspnea and exhaustion, chronic cough with sputum production, and frequent respiratory infection. He reports a significant decline in his ability to perform daily activities. Physical examination reveals barrel chest, prolonged respiratory phase, and wheezing. Spirometry demonstrates a post-bronchodilator FEV1 by FVC ratio less than 0.7 with FEV1 less than 50% of predicted. Which of the following is the most appropriate initial treatment for this patient? LABA, LAMA, ICS, LABA or LAMA, or SABA? So combination therapy with LABA and LAMA. So the most appropriate initial treatment for moderate to severe COPD, as seen in this patient, is combination therapy with long-acting broad beta agonist and a long-acting muscarinic antagonist. This combination provides bronchodilation by targeting different pathways involved in airway smooth muscle relaxation. Thank you for watching. Keep studying hard.